Chapter 11 is going on from acute renal failure going on to, which is progression to chronic renal failure. Okay? Most common cause of chronic renal failure is diabetic nephropathy, by far. That's number one. So diabetes is a big end-stage process of developing renal failure. The way I would look at diabetes is I think of it as a destroyer of small vasculature. Okay? The way it does it is kind of indirect in the sense that it's not because the insulin effects themselves are the problem, it's because the sugar levels stay elevated for such a long periods of time. Your blood literally becomes like molasses. The viscosity goes up because of very high sugar levels of 300 to 400, which is what a lot of these people have. It's uncontrolled diabetes. And when that happens, your blood flow through small blood vessels goes way down. So the glomerulus, which of course are not going to be responsive to high viscosity, are not going to be happy, and that's what you end up seeing. So diabetic nephropathy is something you want to definitely avoid. And most of the time it's an avoided disease. If you keep tight control, and it used to be much more difficult in the past, of course, but now with the insulin pumps that we have available and all this other new technology, most people are pretty tightly controlled. So hopefully the incidence of diabetic nephropathy ending up in renal failure will go down. Okay. Your chronic glomerular diseases such as focal glomerulosclerosis can also do this. Hypertension is also a big culprit of chronic renal failure. And then unfortunately people have the genetic variant called polycystic disease. Okay. Polycystic disease, no matter how good you are, you're going to end up with renal failure in the long term. It just depends on how bad your polycystic disease is. What you're looking at, it doesn't really matter what initiated the cascade event, okay, which is hypertension, diabetes. What you end up doing is you initiate a process which then becomes what eventually develops into renal failure. So it really is a whole cascade kind of event. Treating this secondary phase will slow the development of chronic renal failure but will not eliminate it. You can just sort of slow it down. And some people actually are very effective at doing it. I had a patient who that had developed what we considered chronic renal failure at that point. His creatinine was 4.5, and his BUN was 82 when I first met him. And he completely changed his diet, and his creatinine dropped down to 2.98. Remember that was a weird number. And his BUN went from 80 down to 52. And he basically stayed off dialysis for 5 years and never got any worse. But he changed his lifestyle completely to avoid going into dialysis-dependent chronic renal failure. To this day, I don't know how well he did, but at least after 5 years of being in Tampa, then I moved away. That's the last time I saw him. He was still doing okay. So some people can do well. Okay? What you see is the remnant kidney model of focal glomerulosclerosis. It gives you what's called functional adaptations. You get damaged kidney leads to hypertension. So one of the first things that happens when you don't have adequate levels of perfusion to the kidney is that you will start developing an increasing levels of renin, so the angiotensin levels go up, so hypertension is pretty common. And then they go into a discussion of what's called an increase in single nephron glomerular filtration rate. Okay? Now the way I want to sort of give you this analogy is that your kidney is like a Lamborghini. Okay? It is made to go 120 miles an hour. It loves going that fast. Now, an equivalent to it is a Yugo. A Yugo will still get you there. Okay? I don't know if you know what a Yugo is. Yugo is the worst made car in the world. At least it was when I was a young resident. Pretty much some of us, our residents, we were so damn poor, we had to buy Yugos. So it literally fell apart. Every time you grabbed something, the thing would fall apart on you. But it would still get you there. It would still go you from point A to point B. Now, will it go at 120 miles an hour? No, you're lucky it was going 45, okay, and it was putting around, okay? But it was still getting you there. So when you're talking about the single nephron theory, it basically, you're taking the Lamborghini and you're making it into a Yugo. Wow. It's now you're trying to make it go 120 miles an hour. Can it? Nah, never going to happen. But it sure as hell going to give it a try. Okay? So what ends up happening when you damage lots of nephrons is that the single nephron starts taking up the load. it tries to do everything that the other nephrons are doing at the same time. Okay? So it's really the actual filtration rate depends on the damage, and it's due to a decrease in arterial resistance, especially in the afferent arterial, which leads to an increase in intraglomerular pressure, an elevation in transcapillary hydrostatic or hydraulic pressure, and basically a marked increase in effective renal plasma flow. So in other words, I'm taking my Yugo and I'm not driving at 45 where it'd be comfortable. I'm going up to 80 with it and watching it rattle apart. Okay? Now, can it hold together for a while? Yeah. Eventually, all the parts will start falling off. Wheels comes off. Eventually, it just dies, and that's what you end up having in renal failure. So here's what you see. Okay? With renal hypertrophy, you see an increase in volume of the glomerular tuft, which basically thins out the epithelial cells. What you're basically doing is you're taking a balloon, which is what the glomerulus is anyway, and instead of pumping into it, let's say, a volume like this, you're pumping in a volume like this. Okay, so you've doubled up the volume inside the glomerulus. Do you get more filtration out of it? Absolutely. The problem with it is you're beginning to thin the walls. You're stretching the basement membrane. Remember, it's not made of living structure. It's actually made of protoglycans. It is a acellular matrix. But as you begin to pull it, you begin to thin it. And when you thin something and you put pressure on it, what's going to happen to it? It's going to pop, or it's going to aneurysmal. It's going to aneurysm. Okay? So you don't see an increase in actual visceral epithelial cells, but you see an increase in the actual glomerular tuft size. What you end up doing is long-term increases in glomerular blood flow will lead to epithelial cell injury. So you get the microaneurysm formation. So these little blood vessels begin to outpouch outwards. Okay? You get also what's called hyaline accumulation in mesangial expansion. Now, hyaline accumulation goes like, what does that mean? That means that the base membrane, okay, is normally on a chain. Okay, so if you go to not Starbucks, but Barnes & Noble's here, okay, it's the only place that has it in town where you actually have an escalator going up, okay, and going down. Well, that's what the basement membrane is like. It's like a constant escalator moving in. The cells clean it up, and then they feed it back. Okay? Well, if you tighten that escalator and you pull it harder and harder, what's going to happen to the speed of it moving? It's going to grind to a halt. It's going to slow down. And when you start doing that, you start forming what's called hyaline deposition. So it's protein material that's already would normally be gotten rid of, but now the kidney can't do it. It's being overwhelmed, and the base membrane is basically not doing its motion like it should. So it causes large proteins to thicken, and basically it results in capillary lumen decreasing. The mesangial cells actually increase to try to clean up this mess, which is out here. Remember those guys? Mesangial cells. Okay? And the endothelial cells themselves, which have the podocytes, begin to fuse. They have reduced numbers, and they begin to be very unhappy. They're working way too hard. Okay? Most people that work too hard, what eventually they do? They leave. See ya. And you can't kill people and work them over to death. Eventually they won't take it anymore. So this is what these guys do. They begin to leave. In other words, they begin to die off. Okay? And as a consequence, you look at your diabetic glomerulus. It's much bigger than normal. It is much thicker in the glomerular base membrane because of depositional problems. And your podocytes begin to disappear. So that's what you end up seeing. So this whole thing goes into the whole process. I'm not going to go into all the specifics of it, but this is what I think is a cascade event. Okay, and this is what is actually happening. And people live their whole careers trying to figure out all this stuff out. It's pretty cool. So it goes into a stepwise process. The first one is, back up. Okay, you have your primary renal damaging event. Okay, all right, we're being tricky today. Let's try that. This is your primary renal damaging event, which leads to the systemic hypertension. Okay? This basically then causes your increase in single nephron glomerular filtration rate. This increases the volume in the remaining functional kidney, which leads to an elevation in the hydrostatic pressure. You get an increase in volume and increase in intraglomerular pressure. Eventually what it ends up doing is you get protein loss through the holes. You also start getting volume changes. which causes epithelial cell damage, microaneurysm inflammation, and endothelial cell dysfunction. What ends up happening when you cause microaneurysm formation and epithelial cell injury is that you get things like thrombosis taking place in the capillaries. Okay, the microaneurysms will thrombose, and then if you thrombose, what happens to the surface area? It drops, so you have no more filtration. Okay, so that also leads to a very bad result. Okay, now let's go into vascular and tubular interstitial diseases. Okay, vascular and tubular interstitial diseases are basically broken down into two parts. One, of course, is vascular, so all the blood vessels. Okay, and then the tubular interstitial diseases result from things like calcium phosphate deposition or local ammonia accumulation, which can be very damaging to cells. If you look at patients that have systemic hypertension, they will develop arterial hypertrophy, okay, and eventually cause vascular damage, and they also is called fibrinoid necrosis. The accumulation of ammonia or calcium phosphate deposition will end up causing tubular interstitial diseases. So two different problems. One vascular, being systemic hypertension, the other one due to chemical deposition leading to tubular interstitial damage. Now, the prevention of secondary glomerular injury can be done with certain kinds of different behaviors, okay? But these behaviors are really difficult to sustain. Most patients can't really do this kind of stuff, okay? So what have they done? Well, there's many things that people tell you in the ICU. Well, you reduce protein down, okay? And what you're doing by preventing protein restriction is you get less deposition of protein going into the basement membrane. But one thing that's bad about giving people inadequate amounts of protein is what? Muscle wasting. That's a big issue. And another issue is that proteins also contain in them essential amino acids. So unless you're giving that person adequate amounts of amino acids, you start seeing metabolic problems in individuals. Okay? It causes intraglomerular hypertrophy, reduces the degree of proteinuria, provides segmental glomerulosclerosis, and prolonged renal survival. So dietary protein restriction is actually fairly helpful to a point. Okay? Antihypertensive, in other words, zero proteins is unsurvivable. You can't live with no proteins. But you just got to pick out the right ones. And I can tell you the dietary changes that you have to make to actually take the good proteins in is fairly difficult. Okay? If you look at antihypertensive therapy, the ACE inhibitors, they actually have been found to reduce the efferent arterial resistance, and they decrease the volume in the capillaries as a consequence, and they minimize the glomerular hypertrophy that develops. Okay? The downside, of course, is you can't give ACE inhibitors to somebody who has renal artery stenosis. You fix that another way. There's no benefit in triple therapy because they are afferent vasodilators. So giving hydrochlorothiazide, reserpine, or hydralazine to somebody doesn't really help them. It doesn't unload the glomerulus. This is a glomerular loading disease process. So you need an efferent arterial vasodilator to unload the glomerulus so the volume decreases and the person can then heal. Hypolipidemic therapy has been kind of tricky because we're finding out that people that are put on these kind of drugs, what do they develop? It was actually a pretty big thing that happened about 3 months ago. If you're put on statins, your chance of getting diabetes goes up by 40%. Wow. That should impress you. That should impress me. Okay? So after that I said, you know what? I got to go on a diet. I don't want to be on statins. Okay? So tight glucose control is also pretty critical to maintain good secondary prevention from secondary glomerular injury. Some human studies have been well established and they have large definitive trials. The questions addressed by these studies have actually been answered. Is the remnant model applicable to humans? Yes, it does follow the animal models. And proteinuria is actually a most sensitive indicator of progressive renal disease. Okay, the problem is that it's a 24-hour urine, which most people don't want to do. The clinical implications of hypertrophy of nephrons, it still follows the animal models. And what are the clinical characteristics of diabetic nephropathy is that if you don't get the sugars under control, basically, you will lose and go into chronic renal failure. And is the efficiency of dietary protein restriction and antihypertensive therapy actually work? And that's been very questioned. Nobody really knows. Because unfortunately, if you think it's hard to get people to follow a drug regimen, try to get them to do a dietary regimen. How many people have been on a diet before? How many people were able to maintain the diet? I'm impressed. One of you. Okay? You're lying or you're just unique. You're serious? You're good. I've been trying for 40 years and I still fail miserably all the time. So, but we got to try. Combination of ACE inhibitors and ARBs seem to be effective in heart protection, but not so much for the kidney. So you got to sort of pick out which organ you want to save at times. You got to make sure that you don't have renal artery stenosis when you start these ACE inhibitors on board. If you look at diabetic nephropathy, it's the most common cause of chronic renal failure, of which we're talking about type 1, not type 2. So that's a test question they kind of fool you with. They'll say to you, oh, type 2 diabetic, what's your chance of getting chronic renal failure? Pretty rare, okay? Unless they're completely out of control, okay? Which is then they're developing type 1, and then they require insulin, and they're no longer type 2. Type 1, usually 30-40% of actually these patients will develop chronic renal failure during their lifetime. That's a horrible number if you think about it, okay? It's clinically characterized by proteinuria. That's usually the first sign that they're going into diabetic nephropathy. And then they develop glomerular lesions that progress into an increase in mesangial matrix, capillary collapse, glomerular sclerosis, and loss of GFR. It's pretty much like the same as a single nephron model. And then, like animal model, it goes into hyperfiltration, hypertension, hypertrophy. And how you basically stop the disease is basically give very tight, strict glycemic control. Creatinine levels and proteinuria at the onset of overt disease may not be indicative of severity at times. So you have to do long-term follow-up and see how that person's doing as you change the therapy. Now, if you look at dietary protein restrictions may be beneficial. In response to diabetic nephropathy, there's a normal reduction in individuals over time of 12 milliliters per minute per year. There's a 75% reduction in renal disease progression by putting these people on a dietary protein restriction. So that's a pretty significant fall. Okay, so if you look at this is a person that's developing chronic renal failure here, and this is how fast it'll progress. In 4 years, they'll require dialysis. If you put them on severe protein restrictions, you push it out to almost 12 years. Is it worth doing? The answer is most likely yes. The other thing they're not telling you about this, though, these diets are so restrictive, what happens to most people's weight? They drop weight like it's going out of style. They lose 40 to 50 pounds, if not more. Now, one of the things that you never see in, how many people have seen the patients that have cancer die of renal failure or chronic renal failure? You don't see it, right? It's almost like, wait a minute, what's Dr. Nolan trying to say? Well, when you develop cancer, you begin to lose massive amounts of weight. So even though your kidney's stressed, most of the time you go into renal failure because the body mass index drops off so fast. Cachexia and loss of 50 pounds is usually a very bad indicator of cancer. Okay, so it's one of the things you've got to worry about. Human disease studies the efficiency of antihypertensive therapy. ACE inhibitors seem to slow down the disease, but a reduction in protein excretion should be a primary aim of therapy rather than a systemic drop in blood pressure. The ACE inhibitors, the angiotensin receptor blockers, are equivalent to ACE inhibitors, and really they're saying that the combined therapy may actually give you the best benefit. If you look at calcium channel blockers, like only diltiazem and verapamil, there's a reduction in protein excretion, so that might be also a helpful thing. If you give nifedipine, on the other hand, it actually makes the situation worse. So not all calcium channels are made the same. And then if you give diuretics and beta blockers, there's less predictable antiproteinuric activity, so you don't really know if it's really beneficial or not. I would think myself that beta blockers would not be a good treatment for renal failure. Reason being is what are you doing with your cardiac output? You're diminishing it. So, you know, it's one of those things.